Good evening, everybody. And I'm Dr. Agambura. I'm going to be your host for today evening program on understanding future therapies for asthma. And that too by none other than Professor Dr. Peter Barnes. What a super combo today. Imagine my favorite topic, asthma, is being discussed. My favorite speaker, Dr. Peter Barnes, there. My favorite audience, yes, all of you. My favorite team, that's Shrikant, Manoj, Neeraj, and the whole team of mankind. We've come a long way. Trust me, I began my career some 25 years ago on asthma, and life was very simple. Dr. Barnes, all we used to do would put them on salbutamol tablets, put them on aminophylline tablets, and if they have a little bit of cough, little bit of exacerbation, put them on Visolon tablet, and my job is over. And I thought, what a simple branch I've chosen. My life is going to be very easy. With these 3 tablets, all my asthma COPD problems solved. Very happy that time. And I wondered, can life get any better? And then I saw my first generation inhaler. Again, I was very happy. Then a first DPI was introduced to me, which revolutionized the entire treatment of asthma. And I was super happy. I thought, finally done. One simple inhaler, 2 simple capsules, one after the other, and all asthma under control. And today, after 25 years of so much of development, inhaler after inhaler, combinations after combination, single therapy, double therapy, triple therapy, and my expectations are also rising. I'm looking for now biologics. I'm looking for phenotypes. I'm looking for thermoplasties. I want to give some gene therapies. I'm looking at molecular changes offering which may happen in future in one treatment, disease eliminated. With designer babies that we are going to get in future, probably a lot of us are going to be jobless. To understand and to speculate what future holds for us, we have one of the best speakers today. And yes, none other than Professor Dr. Barnes. Well, introducing Dr. Barnes is like putting a candle in front of sun. Present position is Margaret Turner Wardick, Professor of Medicine at National Heart and Lung Institute, Head of Respiratory Medicine at Imperial College, and Honorary Consultant Physician at Royal Brompton Hospital, London. More than 1,000 peer-reviewed publications. Imagine 1,000. Most highly cited respiratory researcher in the world. Most highly cited clinical researcher in Europe over the last 3 decades. Top 20 most highly cited specialists in the world. Most highly cited COPD researcher in the world for more than 2 decades. That's what is your speaker today. Editor of over 50 books on airway disease and pharmacology. And trust me, there cannot be anybody sitting here today who have not read Dr. Peter Barnes. He's given several prestigious lectures, huge orations at all national and international conferences, has mentored many chest physicians like me, is member of all important professional respiratory bodies, is received innumerable fellowships in our subjects. He is a senior investigator and has more than 1,000 studies which are under his credit or on his credit. So that is your speaker, Dr. Peter Barnes, today. On personal note, my association with Dr. Barnes started about 3 decades ago. And of course, it was one-way association. I knew him very closely. I knew him through his research, through his lectures, through his articles. And I was always found on the last bench whenever he would deliver a talk, be it in Mumbai, be it any of the national conference, or be it any of the international meeting. Trust me, that last bench was not by choice, though I have attended all my lectures during my graduate and postgraduate in last bench. But here, I would not get any front seat because halls are super packed when he delivers his talk. Dr. Barnes, a few days ago, actually, I was talking about dreams. I was giving a small presentation to students and I was talking about dreams. And I said, it takes time. You need to nurture your dreams. You need to visualize it often. And one day it becomes reality. Trust me, I had one dream, and that was to be with you on some program together. It took me 30 years, sir. Even though it is virtual, I'm so happy of being here, and my special thanks to my friend Shrikant and team Mankind for giving me this opportunity. Dr. Barnes, I've been your follower, your student, your disciple for more than 3 decades. And 2 decades ago, I was super impressed with your comment. You made a statement that we have got enough drugs to manage asthma. The future would be how we send this drug to the lung, how we deliver these drugs to the airways. And this would be the future. That is what you said, and I was so impressed that time. Before I hand over this stage to Dr. Barnes, I have one more Herculean task to do, and that to introduce the panel today. We've got excellent panel. We've got 2 giant chest physicians here with us, and we have Dr. Subin Ahmed here. Subin did his MD Pulmonary Medicine and is fellow of RCP London, fellow of College of Physicians, Chest Physicians, US. Currently is the consultant head pulmonology at Kochi, Kerala. Has got 10 publications in a national and international journal. He's a regular faculty at pulmonary conferences, be it national, international. He's got multiple memberships and fellowships to his credit. And he just mentioned that I think in the conference that I got chance to organize, he had delivered a paper there. So I'm very happy inviting you, Subin. Please join us on the stage. And the next faculty that I have to introduce is Professor Dr. S.K. Jindal. How do I introduce Dr. Jindal? A super physician, a fantastic human being, researcher, teacher. Dr. Jindal is a former professor, head of Department of Pulmonary Medicine at PGI Chandigarh, presently the medical director of Jindal Clinic at Chandigarh. He's got 350 publications, wow, to his credit, and in the huge various medical projects that is pioneered. Super presentation, fantastic orator, has shouldered the responsibility of various national and international organizations. And on my personal note, if I have to tell you, I knew him through Professor Mohanty and Professor Dr. Shankar. They used to talk a lot about him. I got a chance to meet him at first time at DNB examination when he was my examiner. And it's my association with him for more than 25 years now. I must thank him for all the love and blessing that he's showered on me. So with this, before I give this stage to Dr. Barnes, I must mention special thanks for Team Mankind, the Express Division. I'm associated with division since its conception. Trust me, I got a chance to host that first ever scientific program, and I'm grateful to them for the multiple opportunities they gave me to be in front of all of you. Special mention for Shrikant, my friend over a decade, very hardworking, dedicated, truly dependable friend. We have Neeraj, Manoj, and the entire team. I may be forgetting a few names, and not to forget those hundreds of Mankindians who would have worked backstage and on the field to make this possible to connect me to all of you. So delegates, get set, get ready to invest your next 1.5 hours into great academics that is going to unfold in front of you. I assure you, this is going to be your best ever investment. Though there are sheer advantages of online meetings, it can happen beyond boundaries, but it lacks physical touch. I miss eye contact with all of you there. I will not be able to touch my mentors. I will not be able to touch Dr. Jindal's feet. I will not be able to touch Dr. Barnes' feet. But chalo, till we meet physically, virtually sahi. Please use the chat box which is there in front of you to get all your queries solved. I promise to you that I will get it solved from these giants today. With these words, Dr. Peter Barnes, over to you.
Thank you very much for your very kind introduction, and I'd like to say good evening to everyone. I've been asked to talk about the current and future treatment of asthma. So I'm going to cover current therapy and unmet needs. I'm going to talk about single inhaler maintenance and reliever therapy and anti-inflammatory relievers. And at the end, I'm going to talk about new treatments for severe asthma, which are mainly biologicals. So asthma is probably the commonest chronic disease in the world today and has a high prevalence in most countries. In fact, the UK has the highest prevalence, with about 10% of adults suffering from asthma at any time. And there's been a global increase in the prevalence of asthma, particularly in low and middle income countries, so that now over 400 million people in the world suffer from asthma. And although we have effective therapies that should reduce mortality, the mortality is not decreasing in many countries, especially in children and the elderly. Asthma is still a leading cause for hospital admission and time off work. We don't have any cure for asthma, so long-term treatment is needed, and this generates high medical and societal costs. I think you will all be familiar with the Global Initiative for Asthma, GINA, which has set out management strategies. And this is the one that was used for many years. It's taken here from 2008. And what you see is an escalation of treatment. And in fact, the severity of asthma is based on the drugs needed to control asthma. So for step 5 patients that have very severe asthma, they can only be controlled on maintenance oral steroids. So the idea is to choose the treatment according to the severity. And for people with moderate to severe asthma, the preferred treatment is a combination of inhaled steroid and long-acting beta agonist. And the reliever recommended is a short-acting beta agonists such as salbutamol or terbutaline. This is a study that really demonstrated the benefit of adding a long-acting beta agonist to inhaled steroid. So in this FACET study, you can see FEV1 improves with an inhaled steroid, but you don't see any further improvement with a high dose inhaled steroid compared with a low dose, which means that for many patients, a low dose of steroid may be sufficient. These patients in the FACET study had what we consider to be severe persistent asthma, as they were on a high dose of inhaled steroid. But you can see that adding a long-acting beta agonist formoterol improves the lung function, and this improvement is maintained over 12 weeks of treatment. A similar study was done in patients with mild to moderate asthma with exactly the same results. So adding a long-acting beta agonist is better than increasing the dose of inhaled steroids. And there's no evidence for tolerance to the bronchodilator effect of the LABA. And yet, although this is effective therapy for most asthmatics, if you look at asthma control in the real world, you can see that it's very poor. So half the patients are uncontrolled and only 28% well controlled in this study, where all the patients had been prescribed inhaled steroids and the majority inhaled steroid with a long-acting beta agonist. And this was a study from 2006, but you can see that a more recent study showed the same problem, that around half of the patients with asthma are uncontrolled or having to use courses of oral steroids, visiting the emergency department, and being hospitalized. Now, this poor control of asthma, despite adequate therapy, is linked to poor adherence with inhaled steroids, which is often less than 20% in the real world, because patients don't feel the inhaled steroid provides benefit like bronchodilators. and is also due to poor inhaler technique, which is a problem in more than half of the people who have asthma. And these two factors account for most of the poor control in the real world. So it's not that we need new drugs, but we need to get patients to use them properly. So the previous way of managing asthma was with a LABA, an ICS-LABA combination treatment given as a maintenance treatment twice a day. And this could be budesonide, formoterol, fluticasone, salmeterol, or BDP formoterol. They're all equally effective. And then patients are using a short-acting beta agonist as a reliever, which are the blue lines on the graph. But a few years ago, a better way of using these treatments was demonstrated. And this is known as SMART, or single inhaler maintenance and reliever therapy, where you use the same inhaler for maintenance, that is the ICS-LABA, but you use the same combination as a reliever. In other words, the reliever also has a steroid in it. And using this approach, many trials showed that the SMART approach was more effective than the conventional approach in controlling asthma. However, the SMART approach is confined to formoterol as a long-acting beta agonist, because formoterol is unique amongst the LABAs in not having cumulative side effects, which are seen with salmeterol, vilanterol, and indacaterol. So you can only use combination inhalers that have formoterol as a reliever as well as the maintenance. And this is a combination of studies looking at SMART versus different conventional techniques to look at exacerbations. And you can see that the SMART strategy, which is the red bar, has less exacerbations than any other of the strategies. And in the real world, this is even more effective. So this EuroSMART study took people with moderate to severe asthma and switched them from the conventional therapy they were taking to SMART therapy. And you can see that there was a 90% reduction in exacerbations. And that's likely explained by the fact that in the real world, patients are not using their maintenance inhaled steroid. So the only inhaled steroid they get in this study is in the reliever. So back to the GINA recommendations, which for moderate to severe asthma is ICS-LABA combination. And this can be used as the reliever as well. In other words, using a single inhaler to control asthma. And this has been recommended by GINA for some time. The majority of asthmatics, however, have mild asthma, which may be mild intermittent asthma or mild persistent asthma, which are GOLD step 1 and 2. So this accounts for 70% of patients, and it's recommended that they use a SABA reliever, and if they have persistent symptoms, a low dose of inhaled steroids. And yet there are really no studies that have examined these strategies. And that led to the SIGMA studies, which looked at the use of an ICS-LABA combination as a reliever in these patients with mild asthma. So the commonest reliever that is used in the world is a short-acting beta agonist salbutamol and also terbutaline. and it's usually used as required for relief of symptoms. However, we know that people using a lot of SABA may actually get worse asthma control. And one of the reasons for this is that regular SABA may actually increase inflammation of the airways. And we've known for some time that overuse of SABA is associated with increased asthma mortality. So in this study that was done in the UK to look into asthma deaths, you can see that although severe patients can die from asthma, also patients with mild and moderate asthma may sometimes die from asthma. So this survey wanted to know if there were any reasons why asthma patients were still dying, despite the fact that we have effective treatment. And the key factors were the overuse of short-acting beta agonist, which may induce inflammation, and the underuse of inhaled steroids, which means the inflammation doesn't get treated adequately, or by using a LABA on its own, as LABA has no anti-inflammatory treatment. So it's recently been shown that if you give salbutamol rescue with a steroid, budesonide, that you get less exacerbations than if you use salbutamol alone. And we think this should also protect people against getting severe asthma exacerbations or dying from asthma, because the steroid that is used in the reliever will prevent asthma death. So the studies on mild asthma looking at budesonide formoterol reliever were known as the Sigma studies, and there are two studies. The first one compared 3 treatments. So one group with mild asthma got terbutaline reliever on its own, another group got budesonide formoterol as a reliever instead of the SABA, and the third group got a low-dose inhaled steroid with the SABA. And what you can see is that the budesonide reliever group had better control of asthma and also less exacerbations than with the terbutaline reliever, and a similar number of exacerbations to the low-dose inhaled steroid. But this was achieved at only 17% of the inhaled steroid dose compared with the low-dose inhaled steroid. In this study, there was high level of adherence because it was a monitored clinical trial. A second study, which was less carefully monitored, compared just two treatments, budesonide formoterol reliever and a low-dose inhaled steroid with a SABA reliever. And what you can see is that there was a similar exacerbation between these two treatments, but achieved at a much lower dose of inhaled steroid. And again, there was quite good adherence in this clinical trial. This is another study that compares salbutamol as a reliever with budesonide formoterol as a reliever versus a fixed dose budesonide. And in this study, which was more like a real world study, you can see that the group with the budesonide formoterol reliever did better than the low dose inhaled steroids. And that's almost certainly because many of the patients in this study were not using their low dose inhaled steroid. And this study also measured nitric oxide in the breath, which is a good measure of asthmatic inflammation, and showed that the budesonide reliever group was as effective as the low-dose inhaled steroid group in terms of reducing exhaled nitric oxide, whereas the albuterol group didn't show any reduction of nitric oxide because it's not anti-inflammatory. And the last study to show you really confirms these studies. This was an open label study in people with mild to moderate asthma. And you can see that when they were given budesonide with the reliever, it was better than giving a fixed dose budesonide and SABA reliever in terms of reducing exacerbations. And that's led to a change in the GINA recommendations. So now for these people with mild asthma, a low dose ICS formoterol inhaler is now recommended in preference to a short-acting beta agonist reliever. And so this becomes the reliever of choice across all the asthma severities. For patients with step 5, some additional treatment is needed because they're not controlled on maximum inhaled ICS and LABA. So in conclusion, for ICS, LABA should replace SABA as the reliever for mild to severe asthma. So in other words, all patients. And this could be ICS formoterol or ICS SABA, although SABA is not quite as effective as a reliever as formoterol, or it could be with a triple inhaler. And it's been shown that anti-inflammatory relievers are more effective for all severities of asthma. They treat the increased inflammation that occurs during exacerbation. It addresses poor adherence with inhaled steroids and is consistent with the patient's behavior that they don't use maintenance inhaled steroid, and is cost effective because it reduces the number of exacerbations. So another treatment that can be added in severe asthma that's not controlled is a long-acting muscarinic antagonist or long-acting anticholinergic, such as tiotropium, where you can see increased bronchodilator response and a reduction in exacerbations on top of ICS LABA treatment, although there's no real improvement in symptoms, quality of life, or asthma control. So LAMAs are indicated particularly in elderly patients that have a more fixed degree of obstruction of their airways, in non-T2 or non-eosinophilic asthma, in patients that have asthma COPD overlap. And we would normally give a 4-week trial of therapy to see if it's helpful to the patient. And if it is helpful, you may consider giving the LAMA as part of a fixed triple inhaler. So we now have 4 fixed triple inhalers that contain a steroid, a LABA, and a LAMA. And these may be given either once a day or twice a day. So this is a study in severe asthma, comparing triple with ICS LABA, and it did show an improvement in lung function, but there was no reduction in exacerbations and no difference in quality of life. So it didn't really add any benefit for this group of patients. So that suggests that we need to be more selective in the patients that are given a LAMA. I want to end with the treatment of severe asthma, which is defined as asthma not controlled despite adherence to inhaled steroids and good inhaler technique. And it makes up about 5% of asthma, but this small population accounts for the more than half of the healthcare spending in asthma. We now recognize there are different phenotypes of severe asthma based on different types of inflammation. So about half of the people with severe asthma have eosinophilic inflammation, which is known as type 2 inflammation. And the remainder have either non-type 2 or neutrophilic inflammation, or they have no inflammation, known as porcine granulocytic. So, as you know, there are now biological therapies that have been approved for treating eosinophilic severe asthma. These are all humanized antibodies and include anti-IgE, anti-IL-5, and anti-IL-4 receptor. So we can see different inflammatory phenotypes in severe asthma, and about 50% have the eosinophilic phenotype. And these patients normally respond to corticosteroids quite well. But in the severe patients, they have a certain resistance to steroids, which means they need some additional anti-eosinophil treatment. And the approved treatments, as I mentioned from the previous slide, are anti-IgE, anti-IL-5, and anti-IL-4/13. There are some patients that have neutrophilic asthma, which is also less sensitive to steroids, and this should respond to anti-neutrophilic treatments. But the only one that's so far been shown to be effective in reducing exacerbations are macrolide antibiotics, and the other treatments have not so far shown to be effective. And then finally, there are patients that are called porcine granulocytic, which don't respond to steroids. And in these patients, there's no increased inflammation. So there may be neurogenic or structural mechanisms. So these are the patients where you may use a LAMA or a triple combination. And some of these patients may be suitable for bronchial thermoplasty and in the future for targeted lung denervation. So the biological treatment that's been used the longest is omalizumab, which is an anti-IgE antibody indicated for severe allergic asthma, given by subcutaneous injection every 4 weeks. And it's only indicated if the total IgE is elevated between certain limits. This treatment's been shown to reduce exacerbations, to reduce the need for oral steroids, and to reduce seasonal asthma when it's used prophylactically. It also treats rhinosinusitis, and we know that this is a very safe biologic because it's been used for more than 20 years now. And here you can see that it reduces the need for oral steroids in severe steroid-dependent asthmatics. So it's a useful treatment, but it's difficult to predict which patients will respond the best. So you normally have to do this by trial and error. IL-5 is an important target for eosinophilic inflammation because without IL-5, you can't make eosinophils. So IL-5 is coming from lymphocytes in the airway, particularly Th2 cells and ILC2 cells. And its main effect is to differentiate eosinophils from precursor cells in the bone marrow. But it's also important for priming and activation of eosinophils and maintaining eosinophils in the airway of asthmatics. So it's a good target to block, and it can be blocked either with a blocking antibody like mepolizumab or reslizumab, or with an antibody against the IL-5 receptor known as benralizumab. So mepolizumab blocks IL-5, and in this study, you can see that with the different doses of mepolizumab that were given by injection every 4 weeks, there was approximately 50% reduction in exacerbations. However, mepolizumab doesn't have effects on lung function or symptoms. Benralizumab is equally effective, but this is more convenient because it can be given every 8 weeks, so less frequent injections. You get a similar reduction of exacerbations, about 50%, to what we see with mepolizumab. And these anti-IL-5 treatments are only effective in people with increased blood eosinophils, which we take as more than 300 cells per microliter. And anti-IL-5 gives little reduction in exacerbations, but it does allow you to reduce the dose of oral steroids in the most severe patients. So these are very useful new treatments for severe eosinophilic asthma. Dupilumab blocks the common receptor for IL-4 and IL-5. It's given by injection, but unfortunately has to be given every 2 weeks. And we know that nitric oxide in the breath is a very good biomarker for this treatment. So when dupilumab is given every 2 weeks in severe asthma patients, what you can see is an improvement in FEV1. So this is an advantage over anti-IL-5. And you see an even greater reduction in exacerbations, in this study, almost by 70%. It's also a very effective treatment for atopic dermatitis and chronic rhinosinusitis with nasal polyps. So it's particularly indicated in patients who have these allergic comorbidities. So other biologics that are in development for asthma are a more potent anti-IgE called ligelizumab, longer acting anti-IL-5, for example, depemokimab, which is given every 6 months, so is more convenient, anti-TSLP, which I'm going to talk about, and anti-IL-33, and some studies with anti-IL-17, which is for neutrophilic type inflammation. So TSLP is an important cytokine in asthma that is produced by airway epithelial cells, and it plays a very important role in determining eosinophilic inflammation because it switches the dendritic cells to a state where they recruit Th2 and ILC2 cells, which are the cells that release IL-5 and IL-4 and IL-13. So by blocking TSLP, you actually block both IL-5 and the IL-4 receptor alpha. So it's like giving benralizumab with dupilumab together because you're affecting both components of eosinophilic inflammation. And this treatment has been found to be very effective. It reduces exacerbations, similar to dupilumab, increases lung function, reduces blood eosinophils, and reduces FeNO, as you can see here, which is a good biomarker for this antibody. And what they found in this study is that even people without increased blood eosinophils respond to tezepelumab. So in a phase 3 study, what you can see is that with tezepelumab, there's an increase in FEV1, as you can see in the graph, and also a reduction in exacerbations. But even in the people with low blood eosinophils, you could see a significant reduction of exacerbations, just over 40%. So this treatment may have a more general benefit in severe asthma and may treat non-T2 as well as T2 asthma. And that may mean it becomes the biologic of choice in the future It's now just been approved in some countries for severe asthma. A similar treatment is anti-IL-33, which is quite similar to TSLP. It's produced by airway epithelial cells of asthmatics, and it is leading to eosinophilic inflammation, but can also lead to neutrophilic inflammation. And there are several antibodies now that can block IL-33. So this is one such antibody called itepekimab, which was given every 4 weeks over 3 months. And you can see that it reduces exacerbations when inhaled steroids are withdrawn compared with placebo, but it had a similar effect to dupilumab and didn't have any additional benefit. So these results are somewhat disappointing, although it's a different study design to TSLP, so it's difficult to compare. So there are several molecules that are now in development for severe asthma. Some of them are small molecules, like DP2 antagonists, but these have so far failed in clinical trials. Another molecule is called dexpramipexole, which is a dopamine agonist and has been found to reduce blood eosinophils, but we don't know whether it has clinical benefit in asthma. There are also treatments in development for non-T2 asthma. So I mentioned that macrolide antibiotics reduce exacerbations, but other drugs have also been tested and so far have been very disappointed. And that includes CXCR2 antagonists, phosphodiesterase 4 inhibitors and P38 MAP kinase inhibitors, but new drugs like JAK inhibitors and IRAK4 inhibitors are in development. So in conclusion, it's important to recognize that asthma is poorly controlled in the real world, despite the availability of very effective inhaled medications. And that's particularly because of poor adherence to inhaled steroids and over-reliance on SABA relievers. So in the future, we have to replace SABAs with anti-inflammatory relievers, which could be ICS formoterol or ICS-SABA combination inhalers, and discontinue SABA relievers, which are potentially dangerous. For severe T2 asthma, we now have effective anti-T2 treatments like anti-IL-5 and anti-IL-4 receptor alpha. And so in the future, we hope that it may be possible to eliminate the need for maintenance oral steroid treatments, which have a lot of side effects. And as I mentioned, there are new biologics for T2 asthma, which also look very promising. And finally, we need to have severe non-T2 asthma treatments in the future because these patients are still very difficult to manage. So with that, I'll conclude and thank you very much for your attention.
Wow. Thank you very much, sir. That was indeed a perfect presentation. I'm sure all of our delegates would have enjoyed this discussion, and I'm sure there will be a lot of questions. By the time I look at those questions, I would invite both the panelists, Dr. Jindal and Dr. Ahmed, to join. And I would request them to initiate the discussion with the question to Dr. Ahmed first. Ahmed bhai, what do you think are the current gaps in asthma treatment in our country?
Thank you so much for the question, Ragam sir. Actually, Gina recently had identified and came up with, they have identified and they have published the current gap in asthma care, which is always inhibiting proper treatment for asthma globally. So they have identified inequity in care discrepancies between different socioeconomic group, populations and ages. There is lack of access and affordability of recommended state-of-the-art inhaled medication globally. The financial part is a huge obstacle. And there is lack of communication and care across primary, secondary, and tertiary care when it comes to caregiving for asthma. And the knowledge, attitude, and practice of the people, the education provided to the patients, those people with asthma, and quality of asthma care plans. Most of them, they think their asthma is well controlled, when in reality, when you deep probably, it's not at all controlled. So, and of course, there had been plenty of scientific evidence coming up, and the scientific evidence coming up and extrapolating that into clinical practice, that is lagging, I felt. That is what Gina has said when it comes to actual delivery of care for people with asthma. So that has to be expedited as well, especially in third world countries and those countries with financial obstacles. So these are the things which Gina had rightly identified for current gaps in asthma care.
Great. Thank you very much for that. And Dr. Jindal, Ahmed Bhai did beautifully mention about issues which are very well narrated in Gina. I wanted to understand from you, what do you feel are the issues relevant to our country? Do you think all this is applicable to our country, or we have some other special issues as well?
I think Dr. Barnes have very nicely introduced the scientific background or the GINA guidelines kind of recommendations, you see. So I don't have any point to add or contest there. But the real world, as you have said, the experience in this country in particular and many other kind of developing countries, or you can say low and middle income countries, are different. One is the extended or the extensive use of oral bronchodilators as well, in addition to the inhalation therapy. See, for example, theophylline remain the kind of one of the most common modality which has been used not only for COPD but also for asthma. Of course, I would agree that other recommendations for the GINA recommendation, many of us, in fact, are already practicing as far as step 1, 2, 3, and 4 are concerned. The second major issue is the use of biological. That also is greatly limited because of the several mechanistic problems, costs, and availability, the fear. The most important is the cost, you see. Many of us have good experience now with the use of omalizumab, but the other kind of the anti-IL-5 antibodies, they are very rarely used, except perhaps in the metropolitan cities where that kind of population does become available and they can afford it, you see. So the of course, as far as the other the mentions like the use of inhalation therapy and the technique, and those points are well made, and we try to teach almost every visit, not only the inhalation techniques, but also to avoid the overuse of SABAs, which sometimes the GPs very frequently continue to use. So these are some of the major issues which are important, and I would say somehow I feel that the use of oral bronchodilators, which has completely gone out of the GINA guideline, is not a good kind of recommendation. See, because there is good evidence, and it's not that they, at least in low dose, you see, they continue to be useful for many of these patients.
Great. Thank you, sir. That's a lovely input. And Dr. Barnes, I want to understand from you, in the similar context Dr. Jindal did mention, when it comes to use of biologics, what do you think is the most relevant factor for not using biologics? Is it really the cost? Is it really the fear of losing patients, or it is lack of confidence? Or maybe, this issues more than cost. What do you think?
Yeah, it's a very important question. I think the cost is a major issue. I mean, for example, mepolizumab costs something like £20,000 a year for one patient, which is enormously more than inhaled steroids and LABA inhalers cost. So we have to be really careful in selecting the right patients to go on biologics because of the cost. And I think one of the things I mentioned that's very important is the need to check for adherence and for correct use of inhalers before switching people to a biologic, because it may be that patients are poorly controlled just because they're not using the inhaler device correctly, or they're just not using the inhaled steroids, which is the case in 80% of people. So it's a big issue. And they looked at adherence in people with really severe asthma, steroid dependent asthma in the UK, and found that less than 50% actually took their maintenance oral steroids. So this poor adherence is a major issue, and it's not an excuse for switching someone to an injection, which of course is a big advantage of a biologic, that you know the person has got the treatment. But I think we have to be really careful about selecting the right patients that are going to benefit from this treatment.
Great, that's a lovely input. So then, Dr. Ahmad, let me ask you in that connection. Sir said it is very important to choose the right kind of patients. How would you phenotype patients in your practice when it comes to asthma? I'm sure most of your patients will do extremely well, provided their compliance is taken care of, provided the inhaler technique is explained to them well. I'm talking about those small proportion of patients who really don't do well and are severe asthmatics, which you make up your mind in about 3 months or 6 months of time with your regular follow-up. How would you now phenotype them?
Sir,
Yeah, well, they're the patients that take up a lot of time. And we really do a full assessment of their history and whether there are any aggravating factors in their environment, whether they might have occupational exposure. Then we check their inhaler use, and we check their adherence, which is quite difficult to do, but you can do it from GP records of prescription of inhaler devices, for example. And then we check their airway inflammation by measuring FeNO, and we often look at sputum for eosinophils, but that's more of a research tool, and we measure blood eosinophils. So FeNO and blood eosinophils can be easily performed by specialists. And I should point out that in the UK, only specialists are allowed to prescribe biologics initially. So they can't be initiated by GPs. And I think that's right, because we want to make sure the right patients are getting these very expensive treatments.
Great, thank you. And Dr. Ahmed, in your opinion, what are
when it comes to
phenotype
phenotyping,
evaluation in our country?
yes, actually, we think about phenotyping our patients only in the later stage 4 and stage 5 patients who falls to the definition of severe asthma, who doesn't respond despite optimal high dose ICS and LABA, or probably a LAMA added to it, or an LTR added to it. So if it's still not getting controlled, or if they are dependent on oral corticosteroids for more than 50% of the year, or if they require hospitalization, ER visits, and poor quality of control, then we label them severe asthma. At that point, we think about phenotyping our patients. So phenotyping, as Dr. Barnes very rightly said, it's based on clinical characteristics, it's based on biomarkers, the endotypes. So we can phenotype our patients into adult child onset allergic asthma, adult onset atopic asthma, adult onset non-atopic asthma, then hypereosinophilic adult onset asthma, aspirin exacerbated respiratory disease. And even of late, there had been entities, phenotypes like asthmatic granulomatosis and asthma in rheumatoid arthritis as well. It has come into phenotypes. And based on the clinical phenotypes, there are glucocorticoid resistant asthma, there is frequent exacerbators phenotype, there is obesity phenotype, and there is perimenopausal onset asthma phenotype as well. And furthermore, biomarker endotypes, we broadly classify them into Th2 or non-Th2, that is eosinophilic or neutrophilic. And as Dr. Barnes very rightly suggested, pheno helps us a lot, and blood eosinophils as well. So based on the blood eosinophil level and pheno, we can classify them into T2 or non-T2. And sputum eosinophil is supposed to be the investigation of choice, but in resource-limited settings like ours, I would stick to absolute eosinophil count in the peripheral blood. So this is how we phenotype asthma. And after we phenotype asthma, according to the specific phenotype, we identify which interleukin to block, or whether it is anti-IgE therapy or anti-interleukin therapy. And then we select the biologics in patients who falls into severe asthma category.
Great. So I got a very interesting message from Dr. Barnes' talk and by Subin Bhai's inputs that for all delegates, I'm told that we've got already 1,000+ logins, live logins at this stage, at this moment. And I'm sure there would be a lot of non-chest physician friends also. I would request all of you to refer all those uncontrolled severe asthmatics to specialist clinic, because they require detailed workup. As Dr. Barnes said, there, and I'm sure here, the use of biologics, the right choice of patient is extremely important. Not only this therapy is costly, but if this therapy requires injectable treatment, and if you've not chosen your patient well, probably it will not do good to them, and it will be waste of energy, waste of time, and waste of a lot of psychological issues on patient's part. So this message must very well be understood. We have a very senior chest physician, Dr. Madhav Kale here, who's joining in from Pune. So Dr. Barnes, Dr. Madhav Kale is one of the senior chest physician here, and I had the pleasure of being with him on a couple of programs. And sir is asking very, very interesting question. He's asking why not to start biologics at earlier stage? Why wait till stage 5 when airway remodeling also is started? Your views?
Well, I mean, it's a good question. I mean, the reason, well, I mean, there are two issues. Is one, whether you should use biologics for less severe disease, like GINA 4, even GINA 3. And the reason we don't do that is because of the high cost. And as I pointed out, anti-IL-5 doesn't improve lung function and quality of life. So you're going to need other treatments anyway. Maybe tezepelumab could do everything, but we don't know that. But it's really the cost. But the other point about early treatment is that if in people with severe asthma, severe eosinophilic asthma, you do want to get them on the right treatment as soon as possible. And that includes some children who occasionally have severe eosinophilic asthma, because as he asks, you want to stop the risk of structural changes in the airway later.
So let me stop you there and ask you again the same thing. Do you really think it's just the cost that is responsible? I mean, is the factors that come to your mind, or do you also feel that many a time just probably stepping up a bit your steroid, a lot of this uncontrolled asthmatics can be bought in the controlled category? Dr. Barnes.
Yes, well, I think a lot of them can be controlled by switching them to an anti-inflammatory reliever. I mean, this is by far the most effective way to improve asthma control, because the level of poor adherence is dramatic in asthma. People are just not using inhaled steroids. I mean, I know that can be a cost issue in India, but I mean, if you actually look at the health economics, and a combination with reliever combination with a steroid in it is actually going to be cost effective, because it improves the cost of managing asthma, reduces the cost of managing asthma by reducing exacerbations, time off work, etc. And I think in the future there are going to be much cheaper combinations of SABA, like salbutamol, and a steroid.
Great, thank you, sir. To the message that I get, and Dr. Kale, please correct me if I'm wrong, that in a lot of situations, when you step up your dose of steroids, that is anti-inflammatory drug, a lot of these uncontrolled asthmatics may be offered better quality of life. They may come in the partially controlled or controlled category, and you may not require biologics there. I understand your pulse when you're talking about preventing remodeling, but trust me, we don't have to wait that long. In next 3 to 6 months of time, after your optimizing therapy and looking at all those exacerbating factors, associated factors, when you realize your patient is still not doing well, I think that would be the time to think about biologics. And trust me, that may not be enough delay where remodeling would start. Next question. So Dr. Bans, you see, now we have got delegate from Haryana as well. Haryana is one more state. So you have from Maharashtra, from Haryana, a lot of delegates are there to welcome you to probably, listen to your talk. The question is amongst these biologics. So we have, sir, 3 biologics available in my country as of now. So I have omalizumab, benalizumab, and mepolizumab available. And Rohit Bhai's question is, which one is best suited for uncontrolled asthma?
Yeah, well, that's an important question. I think if you look at the data from clinical trials, it looks like dupilumab is more effective than anti-IL-5, and anti-IL-5 are more effective than omalizumab. So dupilumab looks to be the most promising of the biologics that are so far approved. But the disadvantage is that it has to be given every 2 weeks, which is not as convenient as benralizumab, which can be given every 8 weeks, for example. But I think in the future, the most promising treatment looks to be tezepelumab. And in a way, it's the opposite of personalized medicine, because it seems to work whether you have T2 or non-T2 asthma. So
Great.
It's going to be a very useful treatment, and maybe eventually could be used even earlier, as we were discussing with the anti-IL-5. The only thing we have to wait for is safety data, because it has a much greater immunosuppressant effect than giving anti-IL-5 or dupilumab. So it may be that blocking all of the T cells is going to have some detrimental effect on immunity. So you theoretically, you could be more prone to infections, for example. But that has to come with the phase 3 studies where they look at safety. So far, it looks to be safe in the phase 3 studies.
Great. I think we've lost Dr. Jindal. Dr. Jindal, are you there? So Rohit Bhai, I'm sure you got your queries solved. As of now, if you're talking about omalizumab, benalizumab, and mepolizumab, we have only 3 biologics to choose from. And what we do as of now is to look at whether it is IgE predominant or eosinophilic asthma. If it is IgE predominant asthma, omalizumab becomes the choice. For the simple reason, one more simple reason, that cost advantage. We have Dr. Bans, we have omalizumab, which is biosimilar omalizumab in India, and it comes at probably 1/10 the cost of original.
Really?
So then that has become very easy.
Yeah,
but somehow,
so that makes it more of a choice.
No, sir. In spite of this being cheaper, I don't see the use of omalizumab going up in that proportion. So there are probably we still lack the confidence of using biologics, which is my opinion. And when it comes to benalizumab and mepolizumab, yes, eosinophils, there is a rising or evolving experience that probably completely wiping off eosinophils may have advantage, and benalizumab may have some edge over mepolizumab is the initial understanding, but I'm sure a careful choosing of patient would be extremely important at that stage. Subin Bhai, let me ask you this next question, which comes from again Maharashtra, and Dr. Sheila Deshmukh wants to know: can we prevent adult onset asthma, and what is the right approach?
As you say, prevention is always better than cure. So adult onset asthma, there are plenty of factors which determines the adult onset asthma. There is smoking, there is air pollution, the air quality, there are comorbidities like GERD, all those things. So I would say you identify the cause and you prevent that. In the sense, you have to get air pollution under control. You'll have to quit smoking. You'll have to take care of comorbidities like chronic gastroesophageal reflux disease. So you identify the factor and you step away from that. Or you take care of that comorbidities. That is how we can prevent adult onset asthma.
That's a lovely input by Subin Bhai, and I can only say that what he said, he started with that prevention is better than cure. Trust me, prevention is not only better than cure, it is easier than cure, it is cheaper than cure. But it's a wishful thinking. I pray, bless, and wish that we can prevent asthma, but trust me, we can't prevent asthma. We may reduce the intensity of asthma. We may improve the quality of life of asthmatics. We may offer them better treatment. We may understand that asthma better, but preventing asthma at this stage, to me, looks far-fetched thought. Dr. Barnes, your views?
Yes, I think there's a big genetic component in asthma, so you have to have the right parents to do well. But I think there are factors like smoking in children is a risk factor for asthma, so you can address that. But there's really nothing you can do to completely prevent asthma that we know of.
We have a question by Dr. Arvind, and Dr. Arvind is from Hyderabad. He wants to know that at what stage we should add oral corticosteroids in asthma management. Your view, Subin Bhai?
Well, oral steroids are of course very useful for acute exacerbations, so that's as a short course. But the use of maintenance oral steroids is very limited. Only 1% of people with asthma require maintenance oral steroids. And the reason why we try to avoid them as much as possible is because of the long-term side effects, obviously. So the only patients who should be given maintenance oral steroids are the ones that just can't maintain their lung function despite maximum inhaled steroids and LABA and a biologic. And then there are a few people where you have to have oral steroids, but the biologics have been very useful for reducing the dose of maintenance steroids. And that's very important because that will markedly reduce the risk of side effects. And we find that with biologics, something like a third of the patients can completely come off the oral steroid. So that's a great function of biologic treatments, is to reduce the need for oral steroids. But hopefully in the future, we won't need to have any patients on maintenance oral steroids because biologics will be more effective.
Perfect. So Arvind Bhai, I'm sure you got your answer. What I do is, your question is what stage we add oral corticosteroid. So you would add oral corticosteroid 1 during exacerbation. And second, in those uncontrolled asthmatics who are on very high dose of inhaled corticosteroids, and in spite, they are symptomatic. In spite of that, they have exacerbation, their quality of life is bad, and their suffering continues. Probably those are the patients you would put them on oral corticosteroids, and a significant proportion of this patient can be put off oral corticosteroid, provided you choose them you're able to phenotype them well. And if they fit into the phenotype where you can offer them biologics, they would do well. And then there are other options available if you phenotype them into neutrophilic asthma or various other types which was discussed. There are newer therapeutic options like thermoplasty, etc. Hi, and I have Dr. Rajesh there, my friend from Kochi. Dr. Rajesh, sir, was the organizing secretary of NAPCON 2018, yeah. I think he was organizing secretary. 19. He organized a fantastic NAPCON at Kochi. And, he has an interesting point, and he wants to know about role of Montelukast in moderate asthma. For that matter, role of Montelukast in asthma. There are two schools of thoughts. One school believes that Montelukast is as good as water. And some school of thoughts believe that yes, Montelukast can be a very good add-on therapy if you choose your patient well. So Dr. Barnes, you first, and then Dr. Ahmed, I would need your inputs as well.
Well, I don't think Montelukast has been found to be an effective treatment in moderate and severe asthma. So, I mean, we actually did a controlled trial where we added Montelukast or a placebo in poorly controlled severe asthma patients in our clinic, and we found there was no benefit of Montelukast. I think its only place is in mild asthma as an alternative to inhaled steroids, but it's not as good as inhaled steroids, even in children with mild asthma. So
you said alternative to my inhaled steroids. You said that?
yeah.
Oh, okay. Interesting point.
So we prefer inhaled steroids in children and adults, and Montelukast is just much less effective as a treatment.
But I have all my life used Montelukast only as add-on therapy. And when you tell me that you can replace inhaled corticosteroids in mild asthmatics, I really fear whether I would be able to ever do so.
Yeah, well, I don't think it adds any benefit once you've got inhaled steroids, because it's much less effective.
Sir, I remember launching Montelukast somewhere in 2003, 2004 in India. I was part of the launch. And, the understanding that time was different. The understanding that time was, as you rightly said, probably for all those children who are unwilling to take inhaled corticosteroids, for those mild asthmatics, for those exercise-induced asthma, which we thought once upon a time exists, which I believe does not exist in my country, or at least in my town, or at least in my village where I practice. And then it is, I thought it would be the drug of choice for all those vagus-induced, psychological asthma, etc. That was my thinking, and I remember very, very aggressively talking about it on various platforms. It took me only 7-8 years to realize that it was all humbug, and the only place that Montelukast had was the add-on therapy. And then came the beautiful time of antihistaminics and Montelukast combination. You will be surprised to know that, sir, we've got at least 20 different antihistaminics, 20 to 9, but at least 10 different, all possible antihistaminics combined with Montelukast. And there would be at least 100 companies making and marketing Montelukast in my country. And every patient gets on Montelukast and antihistaminic combination. I have really found it useful, especially in patients who are uncontrolled with associated allergic rhinitis, where you need additional treatment for nasal symptoms as well. And after 3 to 4 months, I wish to remove that antihistaminic out of it and continue Montelukast. I have enough number of patients on Montelukast, and in fact, I wrote editorial in 2014-15 on the role of Montelukast place in therapy in our country. So I am the one who believes in Montelukast, and here Dr. Barnes is the one who does not believe in Montelukast. And let's listen to Subin Bhai. What does Subin Bhai feel about Montelukast? Over to you, Subin Bhai.
Sir, Montelukast, according to the literature and the drug of choice, it's for aspirin-induced asthma. Apart from aspirin desensitization therapy, which is a bit risky, Montelukast is a safe drug which will take care of aspirin-induced asthma. When it comes to mild asthma, yes, we can give. When it comes to moderate asthma, I would like to reiterate the fact that the treatment of choice is still ICS LABA. You can hike up the dose of ICS. But in this part of the world, I would like to echo Dr. Agam Vora's words. Like we had been getting relatively good clinical results when we add a Montelukast to the ICS LABA in moderate persistent asthma group. Probably difference in population in the West and in India.
And difference in belief system also. I think the most important thing is belief system and individual bias. Sir, whatever you may say, there is a bias in treatment.
I can tell you about that in relation to Montelukast. In our study, because people reported that some patients got a remarkable benefit from Montelukast, we asked the patients if there were any that did really well. And we found some did really well with the treatment, but it was more common with placebo than with Montelukast.
I wish, Dr. Rajesh, you were there live and I could chat with you. But very nice comment is made that choice of biologic for Indian patient with severe asthma with overlapping phenotypes. You have anti-Ig versus anti-IL-5. and choice of Mepoli versus benralizumab. May I request Dr. Barnes to enlighten us that he's talking about overlapping phenotypes. What would you choose?
So I think the question is about asthma COPD overlap.
No, sir. It is about overlapping phenotypes where you have IgE also elevated, eosinophils are also elevated, and you don't really know whether it is atopic or eosinophilic asthma.
Oh, well, I think this is quite an artificial distinction. I think allergic asthma and eosinophilic asthma can be the same. I mean, allergic asthma is eosinophilic, but not all eosinophilic asthma is allergic. So I think the treatments are the same for allergic as for eosinophilic.
No. So the question is, which biologic would you choose? We have now omalizumab, mepolizumab, and benralizumab, 3 biologics available. If you have this severe asthma with overlapping phenotype, and if you have to choose one biologic, what would be your choice?
Well, I think if you want anti-eosinophilic, benralizumab is the best because it's given every 8 weeks, and also it works in a different way, as that it actually clears eosinophils from the tissue. So it probably has a more rapid onset of action. So
I'm also of the evolving opinion that maybe benralizumab may turn out to be a better molecule, and we've come, we've taken a round circle in our understanding about asthma. Eosinophils are useful. Eosinophils are mixed. You may have a useful eosinophil and you may have damaging eosinophils, and now you have all eosinophils which are damaging is the changing concept, and it's going to be very interesting. Next decade would be very interesting, so far as our understanding at molecular level for asthma goes. And Bhumika is there from Surat. So Surat is in Gujarat, supposed to be a diamond capital of our country, very rich city. And I was recently there at Surat last month, and her question is role of rituximab in the treatment of asthma. Do you see the role of rituximab in? Dr. Barnes, over to you.
Which one was it?
Rituximab, sir, rituximab.
Oh, rituximab. Well, I don't think there are any studies published on rituximab. I mean, it does have theoretical benefit because it inhibits B cells that make IgE. So there would be some potential benefit, but I don't know of any clinical trials.
Just adding on to that, I think when it comes to rituximab, when it comes to asthma and EGPA, hypereosinophilic granulomatosis with polyangiitis, the induction can be done with rituximab and the maintenance can be done with mepolizumab. Other than that, in severe asthma, I don't think there is any role or any recommendations of studies, but EGPA is.
So Bhumika, yes, a lot of us have used rituximab when there were overlapping phenotypes with 2 different diseases where you have more of ILD or more of vasculitis or more of rheumatoid arthritis kind and associated asthma. But now with better biologics, I think probably there is shift in the use of use of other biologics. And again, Rajesh is there. He's talking about acceptance of biologics by Indian patients in the light of artwork study. Yes, I am aware that there was a very good study which was done by Rajesh Subin there at Cochin. And sir, they tried to look at the acceptance or the compliance with this biologics there. So I would ask Subin to give a comment on that. Dr. Jindal we've lost, right? Dr. Jindal is not there, right?
I think sir has come back.
So it's back?
Yes.
Oh, I didn't see him. Okay, fine.
Thank you so much for the question, Agam sir, because Dr. Rajesh is my mentor in the field of pulmonary medicine. I learned so many things from him. So the artwork study is one of the hallmark study which is published from an Indian perspective on omalizumab. So according to the study, only 2/3 opted for 2/3 of patients, they opted out of biologicals. Out of that, it was 49% they opted out of biological because of the false perception of good asthma control, when in reality it was not there. They were getting frequent exacerbation. 49% they perceived that they were having reasonably good asthma control. And the other 30% was always a problem, which was the financial burden which the biological was causing on the patient. And 20% of patients in artwork study, they were against parenteral treatment. They didn't prefer parenteral, they didn't prefer injections. And another 10 to 15 patient, they asked that $1 million question to us: how long should I take? And what will be the ultimate outcome? Is it going to cure me? So we were struggling to answer that, the how long part. So they were not convinced on that, and 10 to 15% they opted out because of that. So this was the Indian patient's perception on biologicals based on the artwork study.
Great. We have a question from Dr. Rajshekhar Pareva from Delhi. And the question is the high strength LABA required for asthma management or high dose inhaled corticosteroid? Interesting question. So when you have a asthmatic who's not responding to your conventional combination of say farmetol and budesonide, what would be your next logical step? To increase both, to increase only steroid, or to increase only LABA? Dr. Barnes.
Well, I think that you would normally give them as a combination. I mean, it's very dangerous to give LABA inhalers on their own, because patients tend to overuse them because they get relief of symptoms, but they're not getting any anti-inflammatory treatment. So it increases the risk of death. So you should only ever use a LABA in combination with a steroid. And normally the dose of LABA is fixed. So what you increase is the dose of steroid in the maintenance treatment. If you haven't got control of asthma with a low dose ICS LABA, you go to a high dose ICS.
So we have a very interesting situation here in India, sir. We are spoiled for choices. We have got formoterol available as 6 and 12 available in both strengths. So you have formoterol, which is available as 6 micrograms also, 12 micrograms also. You have formoterol with budesonide, where you have 200 and 400 available. You have even formoterol with 12, which is available with 200 and 400 micrograms of steroids. So now when you have flexibility, what would be your choice? My choice would be to increase both if LABA side effects are not limiting factors. Would you agree to that?
Well, it depends on the LABA. I mean, with formoterol, you can increase the dose without any problems, but with salmeterol, you can't because of side effects. And the same is true with vilanterol.
Great. Thank you very much.
They have cumulative side effects. So you can do it with formoterol. You can go from 6 to 12 for the formoterol and the steroid, but with the salmeterol combinations, you can't do that.
Okay, so it again depends on which kind of LABA you're using.
Yeah.
And if you're using formoterol, yes, you may have the advantage where you can step up the dose of LABA.
Yeah.
The only limiting factor would be side effect. There are a lot of patients who get very bad tremors. So in that situation, you may have to control probably or reduce the dose of LABA. Raipur, Dr. Govind Chandra. Hello, Dr. Govind Chandra. And the question Dr. Govind has is kindly enlighten about the effectiveness of biologics in echo. There is an evolving role of benalizumab again with echo, where you have some data, though very early data, which talks about its utility in COPD phenotype of asthma, but we don't have enough studies on use of omalizumab or mepolizumab for that matter in MEP. Your views, Dr. Subin Ahmed?
Sir, actually, there have been studies are still ongoing. It's still a gray area.
Yes.
Research is still ongoing, and studies have been made on mepolizumab, dupilumab, and benralizumab, as you rightly said. Actually, mepolizumab was showing more promising results with the METREX and METRIO study, which studied the role of mepolizumab in COPD. Even though the study was giving slight positive results, the FDA has not approved it for use in ACO or COPD for that matter. And coming to the BOREA study for dupilumab, There also it's inconclusive. And benralizumab, the biggest study is Galati, if I am not mistaken, when it comes to echo and biological use. So that has given, I'm afraid it has given a negative result. So it's still a gray patch. Studies are still on. We don't have a recommendation for that.
Great. Dr. Poddar is here from Kolhapur, and we have a very nice temple at Kolhapur. What temple? I think Lakshmi Devi's, Lakshmi Mata's temple, one of the goddess, Dr. Barnes, that is very famous and very ancient temple there. Dr. Poddar has a question about immunotherapy in uncontrolled asthma. Do you recommend immunotherapy? Sir is trying to talk about allergy testing and immunotherapy following allergy testing. Your views?
No, well, I think immunotherapy is contraindicated in severe asthma because it can be potentially dangerous. So I think the only real indication for immunotherapy is for hay fever, where people get very severe seasonal rhinitis in the pollen season. It's not very effective in severe asthma. And it could be, I mean, all of the deaths from immunotherapy have been in patients that had severe asthma. So I think it's contraindicated.
So Dr. Poddar, by and large, and somehow we chest physicians don't much believe or like this immunotherapy, though our ENT colleagues and maybe some of the dermatologists prefer allergy testing. I don't know about your experience. I would have preferred to be live with you to understand your views on it. And we have got now, sir, you must have, I think you visited last time Rajasthan, right? You went to Jaipur, I think a decade ago when you were here, if I'm not mistaken, there was a program by
I went to Rajasthan. Yeah.
So you have a fan from Jaipur, Dr. Rohan Saigal, and he wants to know, can we manage environment-induced exacerbation only with allergen avoidance? Oh, that's a wishful thinking. Yes, Dr. Barnes.
Yes, well, it's not very effective allergen avoidance, but the patients like to do it because it shows that they're actively involved in their management. So it's important for things like pet allergy to avoid exposure. For pollen, it's good to avoid exposure in the season. And house dust mite is quite difficult to avoid. So the other thing to avoid is cigarette smoke, including passive cigarette smoke, because we know that's a risk factor for developing asthma and for worsening asthma in children.
We have now a delegate from Chandigarh as well. So Dr. Mandip Kaur Sodhi wants to know, is sputum cytometry available in India? And obviously, Dr. Ahmed, your views?
Sir, I think sputum cytometry is a very cumbersome and very it requires a lot of technicalities. I don't think it's very common in India. I think Dr. Angirya Das Gupta does it in Kolkata, but it's not very common in India. We still rely on blood eosinophil levels.
As of now, it is available only for research use, and not many labs have really developed the expertise for doing this, sputum eosinophilia workup. And then how accurate is blood eosinophil count compared to sputum eosinophils? And trust me, it is fairly accurate. We are not going to be diagnosing severe eosinophilic asthma in one visit. Your patient is going to be there with you for days together, for weeks together, for months together before you actually label him as severe asthma. So by the time you actually start doing their phenotyping, you have this patient's experience with you for some time, and that gives you enough confidence to accurately assess whatever blood report you have in hand. Because by the time you label him as severe asthma, he's going to be on very high dose inhaled steroid. Also, he's going to be on oral steroids. So your eosinophils may not reflect the actual eosinophilia which is there. You have Dr. Varghese from Kerala. And Dr. Varghese wants to know, asthma Th2 phenotype in advanced stages may have bronchiectasis. In such cases, what would you prefer? High dose LABA ICS or biologics in view of chances of infection? Dr. Bans, there's a question that advanced stages asthmatics may have, if has associated bronchiectasis, would you consider inhaled corticosteroid? Would there be increased chance of lower respiratory tract infections? And if patient can afford, can you use biologics?
Well, it depends on the type of bronchiectasis. I mean, recent studies have demonstrated an eosinophilic variant of bronchiectasis that may respond to anti-IL-5, but they haven't done studies yet. But in general, the current biologics would not be effective against bronchiectasis that may occur in asthma. I mean, it would be most commonly seen in patients with bronchopulmonary aspergillosis because they commonly develop bronchiectasis, but it's usually upper lobe bronchiectasis, so that's not usually a clinical problem because the upper lobes are drained by gravity.
Correct. So what sir is saying is depends on severity of bronchiectasis. It depends on what phenotype you're talking about, depends on how bad is patient's otherwise condition. You're talking about a diabetic or renal failure patient or a severely immunocompromised patient having bronchiectasis situation could be different, and a healthy, otherwise so-called healthy person with a small patch of bronchiectasis there could be different. And trust me, this steroid-induced lower respiratory tract is spoken more than actually felt. I have my doubts about this in real world. And if your patient needs for the disease the kind of steroids, don't hesitate in using this steroid because these infections can be managed, if I may take liberty to say so.
Sir,
Dr. Sodi, yes.
for uncontrolled asthma with bronchiectasis, always think ABPA first. You rule out ABPA, and if it is ABPA, of course, omalizumab and mepolizumab have some steroid-sparing effects in that.
Okay, nice input. Dr. Sodi has, which is the best biologic for oral corticosteroid-dependent asthma? It's like you asking me which is the best car, and my answer could be Honda, and Dr. Barnes would say Hyundai, and Subin Bhai prefers Mercedes. So it would depend on what kind of asthma phenotype you're talking about. And we have had that discussion earlier, where it would be very important that you phenotype your patients well and then choose your biologic. We have Dr. Animesh Arya. Dr. Animesh Arya is a senior chest physician at Delhi. And again, I've had a pleasure of being with him on a couple of programs. So Dr. Animesh Arya, thank you for joining us. And sir's question to you, Dr. Barnes, is what is the maximum dose of budesonide in uncontrolled asthma that you've used? And for how long would you give? And what's your experience with ultra, I think it must be the long-acting, ultra long-acting LABA. So Dr. Barnes, 3 questions. Maximum dose of budesonide that you've used in asthma.
The last
Well,
one, LPRA and theophylline, sir. Leukotriene antagonist and
Okay.
theophylline.
Okay.
I think that we've discovered now that there's not much benefit of giving very high doses of inhaled steroid in asthma because the dose response is quite flat. So by increasing the dose of steroid, you don't get any further reduction in exacerbations, but you increase the risk of side effects. So I think that you can double the dose of inhaled steroids, but the maximum for budesonide should be 800 micrograms twice a day. That's the maximum. But most people need a lower dose because it's not a benefit for them to have a high dose.
I think sir showed in very early slide that increasing steroid beyond a point may not really be beneficial, and that is the time you need to combine it with another drug which has got synergistic effect, which has got a drug like probably long-acting beta agonist. And Dr. Ahmad, would you answer the second part about the leukotriene receptor antagonist? I think it's already discussed about leukotriene receptor antagonist and theophylline.
Add-on therapy.
Dr. Jindal did mention that in Indian population, it may be interesting to understand the role of oral drugs, mainly like theophylline. It would be very interesting if we get some evidences from our country about its use. We have Dr. Pardesi here. Hi, Dr. Pardesi. He's from Mumbai. What are the best therapy in pediatric asthma? Subin bhai, would you answer
Oh,
that
I'm-
pediatric
That's
asthma?
not my cup of tea. I've got very limited experience in pediatric asthma. Purely.
Dr. Vance, would you want to comment on
Well,
the best therapy in pediatric asthma?
the
Aerosol
best
therapy.
treatment in pediatric asthma is inhaled steroids.
Hmm.
They're highly effective and you need low doses and side effects are not a problem. So that's my recommendation.
Great, thank you. We have Dr. Ghosh from Calcutta. How do you manage steroid resistant asthma? So we have now been talking about severe asthma, and we have, I think, stopped using those terms, the various terms like steroid dependent asthma and steroid resistant asthma and etc. And now it is put under one umbrella of severe asthma. So I think we don't call it steroid resistant asthma anymore. Dr. Vance?
Well, true steroid dependent asthma is extremely rare. I mean, each specialist may only have 1 or 2 cases in their clinic. And I'm talking about true steroid resistant asthma. People often misdiagnose steroid resistant asthma because they say that they're giving maximum oral steroids and inhaled steroids. And that's almost always explained by poor adherence. So true steroid resistant asthma is very rare and it's difficult to manage.
Correct.
So you use all the treatments that you use for severe asthma. We did show that theophylline has some benefit in these patients. So you may consider to add a slow release theophylline preparation. But it's
long-acting
difficult to manage.
theophylline preparations. Yes, great. And Dr. Parma is from Ernakulam. Ernakulam is at same Kochi, right?
Same Kochi.
It's a near. I've been to Ernakulam as well. Is it on the same road to your backwater?
It's the same, sir. It's just 2 names. It's the same place.
Same place, right? I've been there. So Dr. Parma's question is Montelukast or a combination with antihistaminic, and I think it is always wiser to use combination therapy to begin with if your patient has got associated allergic rhinitis with leaky nose. And once the patient improve at the end of 4 weeks to 6 weeks, in most of the situation, you'll be able to get rid of those antihistaminic and continue Montelukast for some time, which may be 3 to 6 months. And I'm sure Dr. Peter Barnes is not going to agree with me on use of Montelukast, but in India, I'm a fan of Montelukast, so then I would do so in my practice. Dr. Arno Varghese says, can Montelukast be used in children less than 2 years? And answer is no. I think we've got approval for 6 months. No, I'm not too sure. I think 2 years. Dr. Barnes, are you aware?
No, I'm not sure.
I think less than 2 years. No, and trust me, you will not come across situation in less than 2 years where you have to really use Montelukast. Most of this patient would do extremely well with your inhaled therapy. Why can't omalizumab be given with very high IgE levels is the question by Dr. Sodhi. And Dr. Sodhi, yes, omalizumab is a drug for high IgE levels. Only thing is, omalizumab is not studied in all IgE levels. So you have omalizumab study which is available for a particular age group and a particular IgE levels. But trust me, you can always extrapolate your experience of using omalizumab in higher IgE level patients with whatever high IgE levels you have. Only thing is, we are not too sure about dosages. As you know, omalizumab may be available as 150 micrograms a month to about 600 micrograms twice a month. And that is the dose variation when it comes to age and IgE levels. So we would be probably choosing inadequate dose for that IgE since we don't have studies. But yes, you can go ahead and use it if you have exhausted all your resources. Dr. Animesh Arya,
I think
yes.
The problem with the high IgE levels is it's difficult to give enough antibody to neutralize the IgE. So people with atopic dermatitis have very high IgE and they can't be treated with omalizumab because you can never give enough to neutralize the IgE.
Okay. So that's a fantastic viewpoint, which I missed. And Dr. Arya wants to say that why leukotriene receptor antagonist is not removed from guidelines, because I still believe in it. The next question is by Dr. Parmez. Would you prefer vilantrol, fluticasone over Famitol budesonide combination? If yes, in which situation? And I would take liberty to answer those questions. Is we have just evolving experience with vilanterol and fluticasone. I would consider switching to this combination if my patient is stable on that particular dose of steroid, just to improve the compliance, or just if compliance is the issue. If my patient is finding it difficult to take it twice a day, and if this is a control, maybe I would change over to once a day. In a treatment naive patients, I may consider putting them on this combination. If it is mild to moderate asthma, I may initiate with this combination where compliance is little better. Dr. Vamshi, hi, from Karnataka. Dr. Vamshi Krishna is my good friend from Karnataka. He wants to know the difference between salmeterol and formoterol at receptor level. All difficult questions. I would pass it on to Dr. Barnes.
Okay, well, this is quite a difficult question to answer briefly, but salmeterol binds to the beta-2 receptor for a long time, whereas formoterol only binds to the beta receptor for a long time if it's in a high local concentration. So when you take salmeterol and you increase the dose, you have long-term side effects which last for a long time. So when you give more, you have the same side effects going on for a long time. But when you give formoterol, in the airway, it has a long duration of effect because it dissolves in the lipids on the cell membrane. So it's like a slow release. But when it's absorbed into the circulation, it's diluted. And so it can no longer dissolve in the cell membrane. So it loses its ability for long-term beta agonist effect. And that's why you can increase the dose of formoterol without side effects, whereas you can't increase the dose of salmeterol or vilanterol without long-term side effects.
Great. Oh, Vamsi, you were at Vizag, then why it is showing as Karnataka? I think there is some, or you shifted to Karnataka without telling me. So I think we need to speak, Vamsi. Okay. Virendra Vadgaonkar from Aurangabad. What are the contraindications to use benralizumab in severe eosinophilic asthma? And trust me, there are no contraindications. If your patient understands, if your and your patient's goals are same, if you're on similar lines, I don't see any contraindications in using benralizumab. If you are convinced that it is asthma, if you are convinced that it is uncontrolled asthma, if you are convinced that it is eosinophilic asthma, I see no contraindications. Patient having both IG and eosinophilic levels, I think we discussed that in the earlier discussion. The next question by Amit Agrawal is role of bilateral fluticasone, already covered. The next question by Arjun Singh, again Gujarat, role of overuse of antibiotics in early childhood in development of asthma. Is there any role of, interesting, never thought about it. Dr. Barnes, do you think that overuse of antibiotics may lead to development of asthma in future?
Well, that was one theory, that children who didn't get exposed to infections would be more likely to get atopy. And I don't know if that is still true, but there's usually no indication to give antibiotics for an exacerbation of asthma, whereas many GPs were giving antibiotics for asthma attacks. And there's no rationale for that because they're always caused by virus infection or by pollen. Bacteria don't induce
Hardly, correct, absolutely right. And the last question I have on screen is when to add tiotropium in asthma by Dr. Sodhi, again from Chandigarh. And I think I would ask Dr. Ahmad your views on it. When would you add tiotropium in Indian clinical setting of uncontrolled asthma?
Adding tiotropium, we started after the NEJM trial. So we can add tiotropium as an add-on therapy when the asthma is not controlled with high-dose ICs and LABA. And we can add that in stage 4 and stage 5 of GINA guidelines.
Dr. Barnes also beautifully explained about the role of tiotropium in the management of asthma. But trust me, I have of course, again, my limited and my own bias that I have my reservations in thinking that tiotropium would have. So, sir, if I have a patient of asthma with more of mucoid secretions, if I've got asthma which has got some COPD phenotype, I do agree about using tiotropium. But I have not really been successful in getting that uncontrolled asthma to partially controlled or controlled by just adding tiotropium. So I think I have stopped almost adding tiotropium to uncontrolled asthmatics and have started thinking about biologics, I think a step earlier. These are.
No, I agree. I think the problem with adding a llama like tiotropium is that it's not going to improve the symptoms, which is what the patient wants. Is it can improve the spirometry, but it doesn't make the patient feel better. And in the study that compared the triple inhaler with a LABA ICS, there was really no benefit in terms of reducing exacerbations or symptoms, only improving lung function.
Thank you so much, sir. We've had fantastic discussion and I've overshot my time with by almost 40-45 minutes, and still the questions are never ending. I'm seeing some questions on my screen as well. I'm seeing some on my WhatsApp. I'm seeing some on my email, but every good thing has to come to an end. And I wish that Dr. Barnes keeps on talking and I keeps on hearing. It's real music to ears. And when you have Dr. Jindal and Subin Bhai there, which is icing on cake, but the wife is calling, the dinner is ready, and then there are so many issues, you know, Dr. Barnes. So before I conclude this session, I would want your views on what's going to be the future of asthma. Is it the biologics, or do you see a change beyond? Are you expecting something beyond biologics as well?
Well, I think what everyone would like is a cure for asthma, where you just give one treatment and you switch the disease off. And I think one day that should be possible when we understand the immune mechanisms that switch people to asthma.
Great. Subin Bhai, your take-home message?
Yes, sir. I've got one question to Professor Barnes. Actually, Boston Scientific has come out with a statement that they are revoking all supports to Alair, the bronchial thermoplasty machine, in 1 year. So what do you see as the future of a non-TH2 type asthma if thermoplasty is going away from the picture?
You mean the prospects of a treatment soon for that? Well, I mean, as I mentioned in one of the slides, there are a number of drugs being tested in non-T2 asthma. So far, nothing has been effective, but they're looking at new drugs like JAK inhibitors that may be effective.
Wow. Thank you. So I thank Dr. Barnes for sparing your entire evening to be with us. And sir is at London, which is about 4.5 hours. 4.5 hours, right?
Yeah,
4.5 hours difference there. So sir, you spared your so much of time with us, and trust me, your presence is going to make a big difference, and today's date is going to be remembered in at least my memory as one fantastic day where I could get time to spend with you. Though I would have preferred seeing you personally, I would have preferred touching your feet.
yes,
I would have preferred shaking hands with me. I would have preferred your hand on my head, but then I'm so helpless with this technology. So I love this technology, but I'm missing you. So I promise that as soon as things get back to normal, we are going to request you to be here in Mumbai in front of us, with us. And till then, thank you very much, everybody. Till then, thank you. We missed Dr. Jindal. He was there only for some time, and then because of there's some technology issue, and he could not be there. So Dr. Ahmed had to bear the entire bombarding of questions from it. So I'm sorry for that, and I really loved your way of putting things.
And honor.
And the way you have put points is really very, very much it's a great learning for me. I thank you all on behalf of those 1,400, 1,500 delegates who have live joined now. I must thank House of Mankind for giving me this opportunity, and I must thank you for giving me this program. This was fantastic program, and I wish, I pray, I bless that such events, such opportunities continue to come up, and we get more and more of Peter Barnes till he get bored of us, until he says, "No, Agam, no more program with you. I would want Dr. Barnes here." Thank you very much. Thank you, everybody.
Thank you so much.
Okay.
Good night.
Thank you. Great pleasure to see you all. Bye.
Bye-bye.